Hello, everybody. This is Dr. Bawaddaam. Again, Hasnain Bawaddaam. Welcome back to the 2025 educational webinar series. It's going strong this year with some excellent lineup of speakers that we've had so far. And I'm so honored and so thrilled to be inviting my very dear friend and colleague from across the Atlantic, from Spain. This is Miguel Ariza-Prota. And I cannot be happier to introduce him to talk about what he's done to transform the landscape of Cryo-EBUS along with Javier, his colleague. A few words of introduction for Miguel here. Miguel Ariza-Prota is a specialist in pulmonology with a strong dedication to lung cancer and interventional pulmonology since 2014. He completed his training in interventional pulmonology at the Central University Hospital of Asturias and at the Bellvitge University Hospital in Barcelona, Spain. Dr. Ariza currently works in the interventional pulmonary unit at Central University Hospitals of Asturias, where he performs a wide range of advanced diagnostic and therapeutic bronchoscopic and pleural procedures, including EBUS, EUSB, electromagnetic navigations, transbronchial lung cryobiopsies, and medical thoracoscopy, and many others. He is the pioneer in Spain, together with Javier Pallarés of the innovative EBUS guided transbronchial mediastinal cryobiopsy, popularly known now as Cryo-EBUS. And believe me, it's changed the landscape. Ariza has authored more than 30 publications in high impact scientific journals and is an active speaker at numerous national and international conferences every year. He also serves as a current board member of the Spanish Association for Respiratory Endoscopy. Welcome, Miguel, welcome. I couldn't be more honored, and I'll leave it to you from this point on.
Thank you very much. Thank you very much. It's really a pleasure to be here, Hasnain. First of all, thank you for the invitation of the Society for Advanced Bronchoscopy. This is a true honor, and to be here with a friend, it's just amazing. I am at home right now, but I feel more at home because I am here talking to a very, very good friend. So it's an honor. It's a true pleasure to be here, and let's enjoy. Let's enjoy. So I will start right away. First of all, the content of this presentation reflects my personal views, my clinical experience, and interpretation of the current evidence. I take sole responsibility for all the content presented, and I have nothing to disclose. So let's start with music. I am a fan of music. I love to play the piano, love to play the guitar. All these scenes that you see here are in congresses and trainings in Spain. Most of the time I try to open the lectures playing a song, and you will say, why is he talking about this? Well, let me keep going. Let me show you these 6 wonderful songs. I am a fan of 60s, 70s songs. So all these songs that were #1 in the Billboard, and for me are still very famous and will be #1, I think, eternally. These songs have one thing in common, and it's that these songs can be played only with 3 simple guitar chords, all of them. So I'm going to try to share with you how can you perform in 3 steps, in 3 guitar chords, mediastinal cryobiopsy at Cryo-EBUS. I will try to give you all the tips, all the tricks, all my mistakes that we performed during these 3 years, and always remembering that simple does not mean easy, but we are going to try it to be the most simple way of doing this technique. But first of all, why? Why? Let me tell you my why. Let me tell you my story. And my story has a name. I think in medicine, everything needs to be around the patient. And for me, it was Daniel. Daniel is a 19-year-old male. And in 2020, we had a phone call from the hematologist. They wanted to perform a conventional EBUS TBNA on Daniel because they had a very high suspicion of lymphoma. So on November, we performed this TBNA. We punctured station 7 4 times, station 11 RS 4 times. We had again the pathology in our room, and well, we thought we had a very good sample. And at the end, we had suspicious of lymphoma, but we cannot subtype it. Even the flow cytometry was not enough. So Daniel went to a mediastinoscopy, And they got the final diagnosis. It was a non-Hodgkin type B lymphoma, but the mediastinoscopy got complicated. It was a major complication. He had major hemorrhage over there, and he spent even almost 45 days in the ICU. So after this, you start to asking yourself, could I have been, could I have done more for Daniel? Maybe more punctures, I don't know. And in 2022, in January, again, the hematologist called us again because they had a high suspicion of relapse of his lymphoma. So we had to do another conventional EBUS TBNA, and that's when we decided to perform the first mediastinal cryobiopsy on Daniel. And we did it, and we got the diagnosis of non-Hodgkin type B lymphoma. Of course, the family of Daniel and Daniel, they didn't want to go through another mediastinoscopy. In my hospital, it's very difficult that they do re-mediastinoscopy. And of course, with that major complication, it was really difficult to go through that again. So we did it, and we got the diagnosis. So for me, Cryo-EBUS, mediastinal cryobiopsy, is attached to Daniel. So it's very difficult for me, to not be convinced that this technique is really a game changer. And in 2021, it was the first published paper of mediastinal cryobiopsy. The Chinese group published this, and they did it with a high frequency needle knife. They did it on 197 patients, which was a very, very good sample. They got 2 cases of pneumothorax and 1 case of pneumomediastinum using this technique. And in 8%, in 26 cases, the FNA was not diagnostic, but the cryo did establish the diagnosis in 6 non-small cell lung cancer, 6 lymphoma, 1 seminoma, 8 tuberculosis, and 5 sarcoidosis. So at the end, when we read this paper, we said, okay, they said this was safe. I didn't like this complication because we perform around 700 EBUS every year, and we that we know we don't get this type of complications. So in 200 patients, even though they say it was safe, I don't know, this was something that was in my mind. So what we did is that we tried to change the way of doing this approach. We use a needle. So everybody that has a conventional EBUS scope has needles. So we try to make it, to the whole world. The point was not to say, if you have a needle knife, you can perform cryo. If you have a 19G needle, you can perform cryo. No, that's not it. You can have a 21G needle, a 22G needle, and you still can perform it completely fine. So this is my hospital in Oviedo, in Asturias, and this is the way we do it. 22G needle in our IP unit with moderate sedation. We use midazolam and fentanyl for conventional EBUS TBNA, and we wanted to do it the way we do conventional EBUS TBNA. So we do it the same way with midazolam and fentanyl using the 22G Sonotip top gain needle, which is the crown cut needle. I will go through this, but at the beginning we didn't have this needle available. So the first 100 cases we performed it using a conventional FNA 22G needle, and of course the Cryo 2 system and the 1.1 CryoPro. So this is why we decided to change, because when we started, we weren't doing 3 guitar chords or 4 guitar chords, 4 steps. No, we were doing 7, 8 steps before getting the cryo in. We had to puncture 2, 3, 4 times, and then we get 3 cryos. So the procedure was very long. And you cannot be the whole morning doing one EBUS TBNA or one cryo. You have to do, and you have to be very fast. So with this type of needle, you can see you are going to make the tunnel, maintaining the external diameter, and it's going to be easier to get the cryoprobe through the capsule and the mucosa. Of course, if you do this at the beginning, you will have to puncture maybe 2 times, 3 times until you master the technique, which I'm going to talk just a bit about, the Ariza-Pallarés method to performing cryobiopsy. So 3 steps, 3 guitar chords, the planning. I always put planning on the first, then the FNA or FNB, and in that puncture we're going to perform the tunnel, and then we're going to get the cryobiopsy. So step 1, the planning. You have to choose the best place, and you have to choose it wisely. Why? Look, this is the same patient, different cuts in the CT. You have this 4R station over here, lymph node, and you see you have a very, you have distance over here. You have probably 0.7, 0.8 millimeters until you get the needle into the capsule of the lymph node. So before I'm going to perform any procedure in interventional pulmonology, I really want to know if is it going to be straightforward, or probably I'm going to sweat just a bit. So here you can see I keep going down. Now the 4R starts, getting closer to the tracheal wall. And here you can see it's touching it. Also the 4L station. So I know this is going to be very straightforward cryo-EBUS. If it's going to be more distance, I will get it done. You will get it done. But you have to know, and you have to, like get this challenge. So I really always like to do the plan. So this is what you want. You want a lymph node that is going to be with a very thin capsule. Of course, no vessels inside. You're going to avoid the cartilage. This is what you want. Because if you do not choose the best place for making the first puncture, this is going to probably guide the rest of the process. So this is what you want to avoid. You want to avoid a very big mucosa. You want to avoid the cartilage, because here it's not going to be difficult to get the cryoprobe in. It's going to be difficult probably to get the puncture or to get the needle in. So you have almost 1 centimeter to go inside the capsule here. So you have to move the lymph node a little bit to the right and try to find for a better spot. Here's the same with the 4R station. And of course, Doppler mode to avoid any vessel. So step 2, the puncture and the tunnel. When we started, and I have still maintained it, this is a procedure that I believe it's best with 2 operators. One is holding the ebuscope, and the other one is concentrating in making the puncture and getting the cryoprobe through. I'm not saying it need to be 2 bronchoscopies. You can have it. You could be 1 bronchoscopy and your residents, 1 bronchoscopy and your nurse. In our unit, our nurses also can sometimes they do the puncture. So I'm just saying that it's better 4 hands than 2 hands in this procedure. Suction versus no suction. Okay, you're making the first puncture. You go in as you usually do, 8, 10 passes, and sometimes I use suction because I want to have a little bit of blood inside the lymph node, so I can trace very well the needle trace inside the lymph node, because this is going to guide me when I am going to get the cryoprobe in, because this is a completely echo-guided procedure. We are not looking for the whole of the puncture. We are only focusing on the ultrasound image, and you will see this right away. So first of all, the most important part is making the puncture, making the tunnel. So this is the way we use the FNB, the crown cut. We use this type of needle. It's a 22G needle from Mediglobe. And you can see we take the stylet a little bit out, because the stylet comes in this needle before the needle. Then we retract the stylet. Now we have the needle at the border of the sheath. And now we're going to select exactly the spot that we want. And you will see my friend and colleague, Lucia, she's going to give a solid hit, and I'm going to make a pushing. After she makes a solid hit, you will see. She makes a solid hit, and I make a push inside. That's the way that we like to use this crown cut tip needle, because sometimes it's difficult to get it in. So this is the way when we call it the fuetazo hit. So the tunnel, we're making the passes, 8 and passes inside the lymph node, and now we have to concentrate in the proximal part of the lymph node. We have to concentrate in the mucosa, in the submucosa, and in the capsule of the lymph node. Why? Because if you only break the capsule and you do not focus on the mucosa and the submucosa, the cryoprobe will not get in. So at that time, when we're going to focus ourselves in that proximal part of the lymph node, I don't want suction. I close suction because I don't want to traumatize all this part, and I don't want cells from this part of the mediastinum. So I am going from distally to proximal. You will see it on this video. We're making here the puncture. You're making the passes. I'm going to there. My nurse Immaculada is taking the stylet out, and we're making the passes. We usually make between 8 and 12 passes, no more. So now you're going to do what you do not want to do in a conventional EBUS TDNA. That is to go out the lymph node. You will see that my colleague, Dr. Francisco Lopez, now is going to shorten a little bit the needle, and he's going to focus on the capsule. He's going to go out and in. completely out and in. And if you do not feel any resistance when you're completely out, that means the tunnel is correctly made. If you go out and go in again and you lose the ultrasound image, that means the one that was holding the EBUS moved a bit, or you make that puncture when you went out, not in the same spot. So if you lose ultrasound image, that means the tunnel is not completely performed. So this was in Italy at the beginning. This was 2 years ago. I am here making the puncture. It was a 7 millimeter lymph node. You will see that I'm going to the capsule, as you can see here, and then I'm going out and in completely. And I do not feel any resistance. So when I do not feel resistance, I even can talk to my colleague Nadia because I know the tunnel is completely done. So I always ask this question, always in each training, in every training. How does a broken lymph node capsule look like? I always ask, I put this image on and I say, do you think that the capsule is broken? And in this image, you can say, no, I think it's not. I think maybe here. And let me tell you one thing. In this image, I would say the capsule is not broken, but it was actually broken. This is the thing. Can you see now that the capsule is broken? Now you will say, of course, Miguel. Here's the white line, this hyperechogenic line, and then you can see this gray line. Here is the capsule completely broken. But in the first image, it was broken. It was just that my colleague that was holding the EBUS moved just 1 millimeter to the left, and he found the broken capsule. So you need to be very steady, and the movements are not like fast. This needs to be millimeters to the left, millimeters to the right, until you find it. And of course, after you find that capsule, you will find the trace of the needle. That you can always see it. The thing is that you need to find it. You have to make an eye, and you will find it. So this is a very important step. Here you will see this is a trace of the needle, as you see very well, and this is the broken capsule. Okay, so step 3, the cryobiopsy. So you make the tunnel, you're going to find the needle trace, you have to be in the same place and in the same angle. You're going to put the Doppler mode, you're going to use the 1.1 cryoprobe, and these questions are very good questions. Where to freeze, how many seconds, and how many samples are you going to take? You remember in the first study in 2021, they had 2 cases of pneumothorax and 1 case of pneumomediastinum. And this is why we believe this happened. Here you can see that we are freezing for 7 seconds. In that study, they freeze for 7 seconds. And this is what happens when you do this. You do not only freeze the tip, the part that you want to get the sample. You start to freeze the proximal part of the cryoprobe. So if you are in an 11L station lymph node and you're pressing the pedal for 7, 8, 9 seconds and you're very close to the pleura and you're going to take it completely as a block, you're going to take also pleura. So this is why we always say go below 5 seconds. We usually do between 3 and 4, the rule of 3. This is what happens when you freeze for more than 3 seconds. The tip starts to freeze and then the proximal part of the cryoprobe starts to freeze. So in mediastinal, do not freeze for more than 5 seconds. It's not needed. It's not needed. So now this is the part of the cryo. Here you can see the capsule broken. Here you can see the trace. No endoscopic view because we are not looking for the hole. This is completely ultrasound guided. And you can see that the cryoprobe gets in very gently. This is important. You will see a hyperechogenic line here. Non-echogenic and then hyperechogenic again. This is very important that you see that this is the tip, because if you move just a bit, you will think that the tip is this and the tip is actually in the bottom. So you have to find this non-echogenic line very gently, move it to the left, to the right, so you can see it, because if not, you can be further, and if there's a vessel, of course, you can touch it. So Doppler mode, and I am going to press the pedal here for 4 seconds. I am holding it with my fifth and fourth finger. I am taking completely as a block. And you can see the cryobiopsy with no problem at all. And then I will go back in 5, 7 seconds. I go back in and there's no bleeding, and I continue to perform. So at the beginning, this is what we were doing. We were just focusing on trying to look for the hole of the puncture. and the patient is coughing. I think, okay, this is the hole over here. No. Maybe here. No, maybe here. Here, okay. And suddenly it went in. This was on Danielle, and it went in. And we were like, oh, this is wonderful. This is easy. And then we wanted to go to the 11RS station, and we found trouble over there. So you could do this finding the exact spot, the hole. You could have success in 30%, but at the end, with the ultrasound image, you will always get the cryoprobe in. Another good question is, can you obtain samples from different areas of the lymph node? Yes, when we do this. Every time we're going to get a cryobiopsy, we perform it in 3 different zones. Here you see the hyperechogenic, and non-hyperechogenic. Be careful here. This is not the tip. This is the tip, and this is the vessel. So you see, this is the tip. So we usually do it one distally. I'm not going here because this is very, very far away. I'm going to move it right away. That's it. I'm going to take one here, one medially, and one proximal. So I will have 3 different places to get the 3 cryobiopsies, because we usually do 3 seconds, 3 cryobiopsies. And in lymphoma, we usually have or take 4 cryobiopsies when we have that suspicion. One question is, can you do fanning with a cryoprobe? Yes, you can do fanning with a cryoprobe. And we published this like almost 2 years, 1 year and a half ago. And it's the same. You do the same way you perform FNA, FNB with fanning, you're going to do it with a cryoprobe. Lever of the scope in neutral position, upwards, backwards, and the cryoprobe will move distally or wherever you want to put it in. If it's necessary? No, I usually don't do it. Okay, I usually don't do it. Another question, can you perform Cryo-EBUS? Yes, you can. This is the case we presented. We published it 2 years ago. It's feasible. We have now performed around 60 cases, and we haven't got any complications at all. The only tip I can say over here, you see, is the same as the needle. This is a 7 lymph node station through the esophagus, and the same. I'm going to go to the capsule, and then I'm going to go back out and in, out and in. That's the key of this process. That's the Ariza-Pallarés technique. You need to go out. And the only advice that I can give you is to have the cryoprobe, the 1.1 cryoprobe, just next to you. As soon as you end to making the puncture, get the cryoprobe very fast in, because the mucosa of the esophagus closes very fast. You see, I'm trying, and then pump, it pops in. And you see now the cryoprobe in, and you get the cryobiopsy. So another question is, in which station can you perform cryo? In all stations. I always say, if the needle goes in, the cryoprobe will follow. You only need to break the mucosa, the submucosa, and the capsule. Easiest one, 11L. The higher ones, 11L, 11RI, the 7, 11RS. And then usually the most difficult when you're going to make a puncture, sometimes the 4L station, because the EBUS doesn't contact very well, or the 4R because you have this cartilage and all that stuff. So at the end, 4L and 4R are going to be the most difficult for me to make a normal puncture, but also to perform cryo. And this is also a good question. When we go to a training outside our hospital, and they have these cases, and they go, Miguel, Javier, we have this case for you. You're not going to miss this. This is a huge lymph node, 4-centimeter lymph node, suspicious of sarcoidosis or lymphoma. You cannot miss. And Javier and I sometimes we go like, well. And let me tell you why. When you have a very big lymph node mass lesion, and remember, you have to pick up the good spot, the first puncture. You can go here, 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 and they're all good spots. But remember, you have to go out, and then you have to go back in. And because it's so huge, sometimes it's difficult to find exactly the spot if you do not have this very well-defined trace. So when you have a very small lymph node station, 6, 7, 8, 1 centimeter and a half, you will always tell me, Miguel, every time I'm going to make the puncture, I'm going to do it here, here, or here, no more. So it's going to be easier at the beginning to start with smaller lymph node stations than with bigger lymph node stations. So when I have 1 centimeter lymph node station, I'm happy. If I have 4, after you have performed a lot, like always, and you have the experience, it's okay. But to start, I prefer higher lymph node stations and below 2-3 centimeters. That's what I usually advise. And don't forget, lever of the scope in neutral position when you're going to take the EBUS scope out as a block. You want to put it in lever neutral position. Always keep the cryoprobe image on the ultrasound at all times. If you do not see it, don't freeze. Keep the pedal close to your foot, and this is very smart stuff, because you will see that you get the cryoprobe in, suddenly you're going to find or try to find the pedal looking down, and the EBUS scope will move, and you will get the cryoprobe out, and you will have to get it back in. And the pedal needs to be pressed until the sample is secure outside the airway. I'm not going to talk much about the samples. This is cryo on the left side, FNA on the right side. Our pathologist said that when you get cryo, you're always giving them the meat, and if you are vegetarian, you're giving them the lettuce. So they are telling us, you are giving us what we really want. So when not to do it? Same contraindications of conventional EBUS TBNA. If you're not going to perform EBUS, you're not going to do the cryo. Remember, if the needle goes in, the cryo will follow. So just the same contraindications. Remember, the bronchial artery inflow sign. There was a patient that we had. This vessel goes through the descending aorta and passes through all the 7 lymph node stations. So every time we were trying to get the puncture, not the cryo, the puncture, we were seeing this huge vessel inside. So if you see this, of course, cryo is not going to be available, but also the cases that this thing has been described in the literature, they have had hemomediastinal. So if you see this, try to find another spot or run. That's what I always say. So when to do it? And these are possible indications. These are not all the indications that you have, but these are just possible indications. And this differs on the center that you're working. You can have an expert cytopathologist or no. You can have rows. Maybe you don't have rows in your room when you're performing. I mean, this depends a lot. We have places with 90% of diagnostic yield in EBUS TBNA, and places just 1 kilometer away that is 70 or it's 80. So you just have to individualize each case. What we do is, if I have suspicion of lymphoma, I am going to perform mediastinal cryobiopsy. And this means that if I have a patient with enlarged mediastinal lymph nodes, and I don't have masses or nodules, and this could be a sarcoidosis, yes. This could be a lymphoma, yes, cryo. This could be a small cell lung cancer because this patient also is a great smoker. Yeah, it could be. Could be a ganglion tuberculosis, yes. When all these differential diagnoses come into play and lymphoma is there, I am going to perform cryo. Because when cryo says it's negative, it's so high, the negative predictive value, that I am going to believe that it is even negative for lymphoma. And I want to be very, very secure. Of course, in benign diseases, this has also been confirmed. Non-pulmonary or infrequent tumors, seminoma, thymoma, all these that needs very immunohistochemical and molecular study, I'm going to perform cryo. If I perform EBUS TBNA and the sample was not enough, I'm not going to repeat it. I'm going to perform cryo. If I have my pathologist in the room and he says, Miguel, this is a lot of necrosis here. I need viable cells. I am going to perform cryo. In lung cancer, all the study says that it's very similar. 95, the diagnostic yield or the sensitivity of cryo versus 88, 89% in FNA with no differences. But the important thing here is PD-L1. I will show you a paper right now, and we are doing a study right now comparing PD-L1 in FNA, PD-L1 in cryo. And the results are very, very interesting. We can discuss this just a bit at the end. And of course, one of the main reasons also is restaging the mediastinal after induction chemo and or radiotherapy for locally advanced non-small cell lung cancer. That at the end, we will talk just a bit about this. So individualize each case. You have to individualize. At the beginning, this is what we did. We the first 5 cases, it's already published. You only, it's how we do it. So it's step by step. And if you read that paper in 2022, you will see that a lot of things have changed regarding the last publication, because the methodology has been changing a lot every month. So in 2003, we published our experience in the first 50 cases, and we had a diagnostic yield of EBUS TBNA of 82%, and the cryo was 96%. Because this is a complementary technique, and I believe so much in the FNA, together with the TMNC, we had a 100% diagnostic yield. We didn't have to repeat any procedures. But 9 FNAs were non-diagnostic, and the cryo diagnosed all of them. So No pneumothorax, no pneumomediastinum. Remember, 5 seconds and below, and it was very safe. So in this systematic review, I just want to tell you that in these 555 patients that they review here, they found that for lymphoma, and this was at the beginning of all, cryo was diagnostic in 87% against 12%. And PD-L1 was possible in almost all 97% of the cryo-EBUS versus 79%. So when a therapeutic is going to come into play, I really want to be safe and secure that this sample was very good, not only to have PD-L1 positive, but also to say this sample is completely negative. So this is also very important. So we made a proposal for standardizing this technique. At that time, it was 4 steps. Now it's 3 steps, 3 guitar chords, as I already shared with you. And at the end, in all the published papers, no major complications. This seems to be a very safe technique. Learning curve, I believe 30, 35 cases, do it very fast, different stations. And this is something that for me, it's very important. Why I am not using the needle knife? Think when you use the needle, you get a sample, an extra sample that is a complementary. We have had cases that the needle made the diagnosis and not the cryo. This is important. I think it's less invasive. We are more familiar with the puncture than using the needle knife in the mediastinum. Fewer or non-complications. For me, it's faster. 1 puncture with a tunnel, 2-3 cryobiopsies in 2 to 5 minutes. It's feasible, it's reproducible. I think it's going to be for all. I think 100% of patients can benefit. If you have an ebuscope, you can perform it. You do not need to have an electrosurgery system to perform it. So this is one of the things, important for us. And just in 5 minutes, I'm going to explain to you the new technique, because I think you need to know what we were doing 4 or 5 months ago and now what we are doing. We have called this the C-Cryo-EBUS, cryobiopsy through the working channel. We started with 7, 8 guitar chords. We had 3 guitar chords, as I share with you now, and now we pass and try to simplify it even more. I thought this was impossible, but this I think is a really a game changer. So let me explain what we are doing right now. Okay, we're taking the cryo through the working channel of the EBUS scope. And at the beginning, and I don't know why we didn't do this at the beginning in 2022. Everything was just take the sample together as a block. I read this paper, and our colleague Fabian Maldonado, they use here the 1.9 cryoprobe. Okay, they freeze for 5 seconds. At that time, this was 2017. The new cryos were not available. They freeze it in saline. In that tip, you see it's ice over here. So the sample is bigger than the working channel. So they say here that it's too large to be withdrawn through the working channel, regarding the bronchoscope, cryoprobe, and frozen adherent specimen to be removed from the airway and block. And this is what we all have been doing. But we say, okay, let's see if this is really feasible or not. So different ebuscopes brand. And Fuji has the working channel, the smallest one, 2.0. I use Pentax in my unit with a 2.2 channel, and we started, to see if this was feasible. So we freeze here for 3 seconds. The cryoprobe through the working channel of the ebuscope, again in saline, so ice here, and we got the sample in 3 seconds, and you can see there's no freeze in the proximal part. If we freeze for 5 seconds, you will see that you start to freeze the proximal part, as we shown before here. Okay, so if you freeze for 7 seconds, like the other paper are published, you will see that you freeze more that part of the cryo. But you don't want to do this in the mediastinum, and of course you don't want to freeze or be taking the cryoprobe through the working channel, freezing for more than the 3 seconds. It's not needed. So this is what we do. 1.1 cryoprobe, okay, here you have it. 2.0 or 2.2 working channel, depending on the EBUS brand that you have, okay. You're going to freeze with the 1.1, and to get a sample more than 0.5, 0.6, 0.7 millimeters, it's practically impossible. You have a top. That's why you have 1.1, 1.7, and 2.4. You want a more sample. It's not that you are going to freeze the petal for 10, 20 seconds and the ball is going to get bigger, the biopsy. No, it has a limit. It has a top. So here you see that you will have a space through the working channel of almost 0.6 millimeters. So the working channel is not going to be an issue over here. So this is the sample. You get it more elongated. You're not going to get it like circular, like the first one, because you're going to pass it through the working channel. And this is what happens with the biopsy. You see, it gets elongated, it molds inside. This is the video of my friend and colleague Javier Perez-Pallares. We're doing here the complete procedure, not edited, in just 1.5 minutes. We're making the puncture, okay? We're going to make the puncture right now. We're doing the passes. I'm going through the capsule, and then I'm going completely out and completely in, completely out and completely in, and solid hit, as you can see. You see, I'm not losing the ultrasound image. I am not feeling any resistance, so I know now that the tunnel is made. And look at the trace left by the needle inside the lymph node. So now I'm passing the cryoprobe through the working channel. Okay, Javier is not moving at all, as you can see. That's why we said 2 operators. Then you can see the cryoprobe is already in. And I'm going to press the pedal for 3 seconds. I'm going to maintain the pedal press until the sample is outside the airway. As you can see here, I'm going to use my 2 hands and I get the sample. So that's what we are actually doing right now. So the procedure is simpler, faster, safer, because you are staying in. You don't have to go back or go out. So I'm just going to talk 1 minute of 2 studies right now that I believe are very important studies for in 2025. This is just a recent got published. Is comparing cryo in lymphoma, FNA versus cryo. 12 hospitals here. So in 40 patients, the cryo sample got the diagnosis in 38 of 40 patients. And this is a very important, I think, game changer. Here you can see the sensitivity, 95% versus FNA plus flow cytometry, 25%, only 8 cases in the 40 cases. We avoided 32 mediastinoscopies here. And when we were seeing the new diagnosis, 24 of 26 patients were diagnosed with cryo. When you get the recurrence, 100%, 14 out of 14. So this is very important. Just get in mind that if you think lymphoma, go for cryo. This is the last paper published in restaging with comparing FNA and cryo following neoadjuvant therapy. 22 patients, and this is very important. Of the 22, 21 patients were diagnosed by the cryo. And 16 of them were malignant, 5 were negative, and 1 was non-diagnostic. And all those 5 that were negative were confirmed by mediastinoscopy. So, and that was non-diagnostic was suspicious of lymphoma. So at the end, it's like you knew that all these 22 cases, you could be like safe and you could be secure that the diagnosis, you have a very high negative predictive value. And other important thing is that the sample adequacy for molecular and immunohistochemical analysis of the cryo was 94%. And in those cases are very important where you're doing restaging again, because if it's positive, you're going to have to perform all the immunohistochemical and all the molecular determinations again. So cryo secure this step also. So just, I am ending here. This is my final, my conclusions. Cryo-EBUS is safe, it's minimally invasive, strong evidence support that in lymphoma, rare mediastinal tumors, benign diseases, post-neoadjuvant restaging in non-small cell lung cancer, lesions with large necrotic components. I think this is a first line, and I think we should go there. And of course, the new version of the mediastinal cryobiopsy through the working channel, it's I think it's going to be a revolution because you maintain continuous visualization. The complications because you are going to be lower, and you're going to optimize time and of course resources. And important, the learning curve. It's so fast now to perform it that you don't have to go in and out so many times. So these are my conclusions. If you do conventional EBUS, you can perform cryo. If you don't believe in what you do, don't do it. I think this needle is very important at the beginning for beginners because it's going to make it easier for you. If your diagnostic yield for all mediastinal pathologies is above 96%, then don't perform cryo. And always remember, keep it simple but significant. So this is our unit, my colleagues. And of course, again, thank you very much for the Society for Advanced Bronchoscopy for this invitation. And it's a completely honor and a pleasure to be sharing this lecture with you, Hasnain. It is wonderful, really. Thank you very much.
I want to, first of all, thank you. Thank you, Miguel, for this talk. Excellent presentation and very well depicted, very well illustrated, and very well explained to the our general pulmonologist advanced bronchoscopy community as to how to go about doing this. First of all, I want to congratulate you and Javier both on the 2 recent papers in 2025 showing the yield with the cryo-EBUS and lymphomas, and secondly the restaging that you came up with in the journal Mediastinum. I do have a couple of questions, and I was making notes as we go about. The first question I had before we even started the lecture was, how did you and Javier come up with this? And you already answered with the patient story of Danielle that stirred you up to avoid another mediastinoscopy and lymphadenectomy, and that's how this came about. But could you speak to the size and the architecture of the cryo samples in improving this immunohistochemistry and next-gen sequencing that we do? Because it really fascinates me that PD-L1 cellularity and adequacy is more with cryo samples than a TBNA sample. Could you talk a little bit? Is it related to the freeze time and having more sample? How do you explain that?
Our pathologists right now, what they are saying is the architecture of the sample, the well-preserved architecture of the sample of the cryo. We are even making a study right now for them that maybe 1 cryo, not 3, because we're doing 3, but maybe 1 cryo, they are saying sometimes with 1 it's enough. You don't have to do 3 or 4. That's what they are saying right now. And it's because not that the sample is bigger, which is bigger, but it's because of the architecture and the well-preserved sample for the PD-L1 that they say that here that this can play a key role. So we are doing this study like for a year right now, and we're comparing it. And I can tell you just a bit that there are some patients that with the FNA performing 3 punctures versus 3 cryo, the PD-L1 was less than 50% in a few of these patients and was very high, above 90%, the PD-L1 with the cryo. And when this enters the game, that you're talking now about treatment, this is key. Because sometimes in our multidisciplinary committee for cancer, the pathologists go and say, in this sample, the PD-L1 was negative. Yeah, in this sample. But was the sample good enough? You know what I'm saying? Was the sample good enough? So that's the question we are trying to answer with this study that hopefully I think it will get out or go out next year. But I think it's the architectural part of the sample, not the size. The well-preserved sample where PD-L1 I think plays a key role in these samples. Yeah, it's a very, very good question.
Thank you. And I want to myself testify to when you talk on lymphoma and the yield in lymphoma, because several studies over decades have now shown the yield of EBUS TBNA with lymphoma in de novo cases is about 50 to 60%, and recurrent has been about 70 to 75%, about-ish. And now this is taken to a whole different level where de novo lymphomas with cryo-EBUS are now being seen in several papers. We have a paper from you guys, we have a paper from Switzerland with Thomas Geisel and Carolyn and group there. And ourselves, we just submitted a paper as a multi-center study, including myself, for de novo and recurrent lymphomas in the US, which is it is a significant difference. And it is taken up to an 85, 90, above 90% yield that is now consistently shown for lymphomas with cryo-EBUS. How do you say this has been game-changing in your practice for lymphomas?
At the beginning, I remember that just the first 2 years with all the published paper, few cases you got like 4 patients were diagnosed with cryolymphoma, 7 in this paper, 5 in this paper, but there wasn't really comparing in this type of patient, what's really going on, even in de novo and in recurrence. In my hospital, my experience is very bad in diagnosis lymphoma with FNA. In my hospital is below 40%. I am like between 30 and 50% in de novo. Probably 60, 65% when I go to recurrence. And flow cytometry, I don't know why, they less than 30%. So they always tell me apoptotic cells, hematic, it's lymphoma, but we cannot subtype it. So, I mean, I think this is really something that the societies and the guidelines need to be, focusing on. Because what I did now, it's like, I had a meeting with my hematologists, all the department of hematology. I explained this study to them, and now, they are sending us more cases, and they are avoiding more mediastinoscopies or going to another targets. Take the axillary lymph node out, or go and take the super. I mean, it's more invasive than to perform a cryo, which is 15 minutes, 20 minutes, no more. So I think the societies and the guidelines need to be just focusing on this, because you are avoiding complications, you are saving money, and of course you are making the diagnosis for these patients, which is, it's very, very important. So I am for me, this is the most important part of it, lymphoma, for me.
Well said, because you're right. We've seen the same at our institution, where flow cytometry has not been of much help, and lymphadenectomies from either that site or from mediastinum or axillary is not the answer. Lesser invasive procedures are there and are good options to pursue. One final question for you. Cryo-EBUS is now being revolutionized, and several interventional guys and advanced bronchoscopists are using it across the world. And a lot of responsibility on folks like you and Herth and Hari and Swiss guys who started this, in 2020, 21, 22, and 23, you and Javier brought about this minus the needle knife technique. A lot of responsibility on you guys for the rapid uptake across the world that we're seeing now, and a lot of folks doing this. What do you see is going to be the challenge? And I liked your last slide that you put up, Miguel, that if you don't have the confidence, don't do it. If you think you're not going to be able to get in, don't do it. If you think it's not needed, don't do it. A final word of advice for folks, not just to get on the train for everyone to do it. How do you take that responsibility?
Yeah. I remember at the beginning of all this, here when we started this, a lot of people were very skeptical with this, because I have a lot of friends over here in interventional pulmonology in Spain, and at the beginning they told me, this is not going to work, because I have a 98% diagnostic yield in my hospital in all the pathologies. And I was like, oh my God, I have to see what am I doing, because I do not have this diagnostic yield. In all the papers that are published in all those centers that have all the means, rows, expert cytopathologies, and they have 90%, 88% in FNA. Those are the top ones that have it all. So sometimes I think we live in a bubble, and we are trying to compare to those places, but those places are the exceptions. It's not 85, the diagnostic yield FNA in the world. I know it's below. And I know it's not 70 in lymphoma. I know it's below. I know it's less in sarcoidosis. So at the beginning, they told me this is not going to work, because we have this very high diagnostic yield. And for them, it's that final conclusion. If you have a diagnostic yield so high, don't get in this train, because this is not for you. This is for me, because I really need it. And I think we need to individualize each case, individualize each center, because each center is completely different. You can be very strong in lymphoma. I can be very strong in sarcoidosis. You can be very strong in lung cancer. I can be very strong in, So what I believe is that everybody needs to know how to perform this technique safely. They need to have it in their portfolio, because in some cases, the patients are going to benefit. And then you are the one that are going to put the indications right where you think you are going to be better in your place, in your hospital. So what I really always say is share everything, because I'm not saying those are the indications. No, possible indications. Use it wherever you think it's going to benefit your patients. That's my final.
I loved it. I loved it. Thank you so much, Miguel. It was an excellent talk. I learned so much. I've been using this, and since we've talked in several studies now, and I'm honored to be a part of your next study. But this is revolutionary, and it is game changing, and it has helped my patients as well at my institution and several others. So thank you to you and Javier for all the work you do and the dedication you provide, in all sincerity.
No,
So thank you.
thank you very much, Hasnain. Thank you very much. It's a pleasure to be here, and hope to see you real soon here in Spain, or I will go to your place. That's for
Good.
sure.
Have a
Thank you.
wonderful day.
You
Bye
too.
bye.
Take care.